So, Ralph, welcome back. We are very happy to see you again, now from your new working place in the St. Gertrauden Hospital, but we are very happy also for this transmission in cooperation with the Vascular Center in Berlin.
Okay. Hello, Dirk. So we are not showing a valve case, but something which I think is also a lot of people just talking about renal denervation, and I just expected that you already had shown the data from reduced hypertension, but probably it will be just the next lecture after our live case. So I'm here with my coworker Andrea Bene, and also with Helena, and also with someone from the anesthesiology department. He's just taking care of the pain, Jörg Weimann, who's just cooperating here with us. So maybe Andrea can briefly introduce the case we just scheduled for this technique here today.
Yes, good morning to Leipzig. I would like to introduce you a female patient, 73 years old, who has a long history of atrial hypertension. Her official blood pressure is 178 to 95, and she already had 6 different antihypertensive pills, you can see here. She also has a chronic heart failure and an atrial fibrillation besides. We did a duplex ultrasound of the kidneys before, where we didn't see a renal artery stenosis, and we had a resistance index on both sides, bilateral, of 1.75. The next slide, you can see the CTA we did before, also shown just a singular artery of both sides. And we already did an angiogram, so Ralph can show us the new pictures now we already did.
Yes, so maybe you just can see what we did just in the very beginning. We just took a picture of the anatomic overview, so the slightly steep bifurcation or offspring of the right renal artery, so the left one is more or less straight, and just we wanted to use the Vasix system here, so it's running on an 8 French sheath, which I think is just has to be improved, and we had an 8 French Ansel sheath from Cook right in place, and we already intubated the right renal artery because we just thought it's the slightly more difficult one. So as you know, it's this reduced hypertension, or this Vasix system is working with a balloon with bipolar electrodes. Maybe we can show you just briefly the balloon. So maybe, I don't know, ein weißes Tuch, genau. So maybe you can see the electrodes here. Whether it's better to switch on the light. No, yet you can see the electrodes right here. So we are with our sheath, as you can see here. That's the Ansel sheath, so slightly far away from the ostium of the right renal. We have an 018 wire in place just for slightly more support. We thought it would be just a good advice to get this here in place. Schon 2-3 Minuten hätten wir das. So I'm going to introduce the balloon. I think the technique itself is just not really cumbersome. It's just, in most of the cases, the renals are easy to intubate. I don't know whether this would be just really very easy with the left one, but you see the balloon can track very easy into the renal here. I just make a shot just to see where we are. So slightly far, maybe we just go a little bit back here. Okay, so we would be just ready for the activation of the generator system. So we just measured the artery in the by CT scan. It was just around about 5.8 something. So we've chosen a 6 millimeter balloon with 8 electrodes on it, and maybe we can just show you the generator. Okay. Okay. So already we just have contact with 6 electrodes already without inflating, so they're just on the wall. Okay. Now we just connected our indiflator here. And we are going to activate it here with 3 atmospheres. Then we just will take a second shot to see whether we close the artery and have wall contact. So 2 electrodes are not working. We just have 4 atmospheres. We just have 6 electrodes activated. Just make a second shot to see whether we have flow or not. So I think we blocked the artery totally. And haben wir einmal gesehen? Okay, so I think we just can activate it. It's just taking only 30 seconds, so it's quite a fast procedure compared to others.
Yeah, so as you say, it's a simultaneous ablation at 8 points during 30 seconds. It's still a painful procedure for the patient. So you're having the patient on general anesthesia or on anesthesia?
Yes. So she's just Professor Weimann just gave her remifentanil and a little bit of dormicum. So we can now deflate the balloon. We just had 30 seconds of activation, and I think we're done with the first side, so it's quite fast and easy, and I think she just felt some pain. Okay, die Hände müssten mal ganz kurz. So she's got the hands at the belly, so she had some pain, as you can see. Genau. Einmal die Hände müssen ganz weg, bitte, aus dem Bild. Okay. So we just try to get the balloon into the sheath back, and we are just
Hello.
do not remove the balloon totally. You see here, now we are just in the sheath.
So there is a question here.
Yes.
So Ralph, there's a question from Bill Gray.
Hi. Very nice job so far. Increasingly, there's conversation about the anatomy of the perivascular nervous system, both sympathetic, efferent, and afferent. And while there's a greater density of nerve fibers, the more distal you go in the renal artery, there appears to be a source ganglion at the site of the origin of the renal artery. And I just wonder, in somebody who's practicing renal denervation, we don't have this yet in the United States, do you focus on trying to get that osteal ganglion set up, or at least as close to the ostium as possible with your denervation strategy? I noticed here you were about probably 3 or 4 millimeters off the ostium, but it may not be an issue. I just wonder what your philosophy is there.
So honestly speaking, so we are... we just had some cases where the artery is really, really long, so we tried to inflate the balloon for several times. But in this case, so the artery was measured somewhat smaller. We do not go so close to the ostium. So maybe I can just turn the sheath a little bit. It's
yeah, so it does.
As you can see. So
looks a little bit like you would need a different shaped catheter here to maybe better engage the osteomer.
Yes. So I try to get the balloon somewhat back, just to have a little bit more.
So which shape is that?
Freedom of my wire. So it's the Ansel, 8 French Ansel sheath. So it's the only one which is weighable for this balloon, which I think is just. Kannst du mal den Draht einführen kurz? So we are. Maybe Andrea now is just going to keep the sheath, and she's tried to probe the artery. So otherwise, we just have to exchange maybe to another wire. We just have the. Yes. Okay. Okay, so we get the wire into the renal. Maybe we check once again. To be sure that we are just in the right place. Yes. So now the balloon is just, it's already used, but I think, einmal kurz den Draht, we try to advance the balloon gently. That's okay, ein bisschen halten so. That's following quite nicely.
Well, that's actually pretty impressive, yeah, with the lack of support here from the sheath and the guiding catheter that the balloon
so
still
I think
makes
that's just one of the things which are just suboptimal, that we just have not a great variety of sheaths we can use, just only one available with somewhat like an angled sheath, so no RDC shape is available, but I think that Boston is working already on this problem, and there were just some prototypes available from another company, but they were just not that good. Okay, so I think I will not advance the balloon further because I'm just afraid that I go too far away into this side branch here. So honestly speaking, it's just a very short artery or main stump of the artery, so
but there's always the possibility to keep the balloon a little bit extending into the aorta, so that maybe only the 6 distal electrodes would be activated, so you can adjust that.
Okay. So I think now I'm just in a more or less good position. What do you think? Do you agree?
Absolutely.
So we're just in the main branch, and maybe that's just directly at the ostium of the renal. Okay, so I'm going to once again inflate the balloon with 3 to 4 atmospheres, and
How often do you find yourself using two different sized balloons in a single patient?
it depends on how many renals you're going to treat. If you just have small ones, I think you need a second balloon. So here I see the electrodes are just not all, so they are activating. Yellow means, if you see the generator right now, okay, yellow means it's somewhat activated, so I'll just maybe, okay. So we're going to control the occlusion to once again inflate. Okay, so maybe the proximal ones are just not activated, but they do not have contact, but I think the renal just is occluded. And so we're going to activate it once again. So 30 seconds.
Yeah.
All 8 are now activated.
Yeah, very impressive, Ralph. I think we have to take advantage here of the fact that this procedure is very quick, because we are not so quick here, unfortunately.
And honestly speaking, it's just from the procedure itself, I think it's just not that interesting, but I think the end point, as we are all looking forward to ACC from Simplicity 3, is really important. And I think it's very good that I think we just have to probably look for subgroups and see whether there's benefit for those patients. And I think it's good that Boston Scientific is still working on this topic. And Dirk, I think you're going to present the data very soon, right now?
Yeah, absolutely. We're going to take a look a little bit at the data.
Okay.
So
I will now inject and see whether we caused any dissection or something like this on the renals. Okay, so they both look still good. No damage to the artery itself. I think also the other one is just still looking good.
Yeah.
So, honestly speaking, we are done. So that
Good.
was
Ralph,
a
well,
quick procedure.
Thank you very much. So I have to push, unfortunately, a
later.
little bit. Next time we come back, we hopefully have a bit more time. But thanks for showing us this procedure in such a straightforward way. Well, thanks very much to Berlin.